Good morning, everybody. I'm Atika Adias, a lecturer from University of Mitra Indonesia, and also I'm a coordinator expert of the Indonesian Association of Health Insurance Professional PAMJAKI. Thank you for Korea Health Insurance Review and Assessment HIRA in inviting us to share our experience. In this part, I will be presenting the universal health coverage in time of crisis Indonesia experienced to overcome COVID-19. And in the second part, my colleague Dr. Nani will present her experience how to deal with COVID-19 in the district level, especially in hospital. In order to achieve universal health coverage, Indonesia has gone through several policies adjusted to operational development that are considered more efficient and effective. Indonesia has been reforming its health sector since 1992, stated in the Health Act number 23, which encouraged the method of integration of financing and services for the various health plans, civil servant, formal sector, informal sector, local scheme to be managed in efficient and effective way. But because it was voluntarily scheme, so that the coverage is very low, about 50% of the population. The next reform occurred in 2004 with National Security System, unified the health system extended coverage, and implemented compulsory membership. But the coverage is still low, spread across several schemes, about 25%. Meanwhile, the government preparing regulation for implementing the national schemes. In 2011, the BPJS Act number 24 was issued. All the plans were consolidated under a single payer BPJS, and all schemes merged into a national risk pool. In 2014, Indonesia Universal Health Coverage Program JKN was launched. Right now, the coverage is increasing up to 222 million population, or 85% by April 2020. What is the operational design of Indonesian UHC JKN program? There are four main stakeholders who play a role in implementing the Indonesia UHC JKN, and several things can be explained as follows. The member JKN consists of the poor, civil servant and army, local workers, and informal worker. Second, the BPJS, a public entity under the president, receive the prepaid contribution. The poor is paid by the government, while civil servant and formal workers contribute 5% of salary, with proportion 5% from the employer and 1% deducted from the worker's salary. The contribution of non-winners is in cash. Third, the provider is the network health facilities. This network consists of first-level services, referral specialists, and inpatients. Both government and private health facilities are making a contract with BPJS. The government, the Ministry of Health, Ministry of Finance, National Social Security Council, and other ministers are that regulator the carry out of the supervisory function of the implementation of the JKN. How Indonesian UHC JKN program works? To answer these questions, there are a lot of studies, but in this presentation, I will share the qualitative assessment conducted using the JLN tools. JLN is the Joint Learning Network for Universal Health Coverage, with a practitioner-to-practitioner learning among 34 countries right now. And South Korea is one of the JLN steering group. The assessment results shown that Indonesia UHC JKN get high score of 6 policy priorities to achieve the objectives. Score 10 were given for financial protection and sustainability. Score 7 for equity and efficiency. The Indonesia UHC JKN program also helps fulfill the 6 criteria of the policy domain in formulating the benefit, mobilizing resources, provider payment, supply side strengthening, generating income, and protocol and pathway, accountability. This tool also used to evaluate the 6 JKLN member countries You can get the detail of study in the JN web. Now, what is the effect of COVID-19 to Indonesia USCJKN program? To answer these questions, let's see what situation of COVID-19 in Indonesia. Although the number of cases is increasing, the cure rate is getting better and the mortality rate is decreasing. By October 14, this is in the slide, is September 27, but I get the latest figure by October 14, confirmed about 344,749 cases, cure rates 77.7%, and death rate 3.5% confirmed. What the strategic Indonesia to overcome the COVID-19? As soon as of the outbreak, the government declared that COVID-19 are the public health emergency status and national disaster. So that the government established the task force for COVID-19 at national, followed by the local government. Just a few weeks ago, the president directed effort to reduce the number of cases. Second, we implement the WHO recommendation, a lockdown. In Indonesia is translated as large-scale social restriction or PSBB, which is done in some province and district as well, depending the situation in their area. The second, we do the socialization and monitoring of health protocol into community behavior to use masks, keep your distance, and wash your hands. Third, social surveillance by the health office, tracing, testing, and treatment with the involvement of community leaders. 5, we're seeking to vaccinate 100 million people by January 2020. What the effect of COVID-19 to the health services? As we understand that people are afraid to go to the health facilities and also because of social restriction. Some studies show the effect of COVID-19 to the health services as follows. At the beginning of outbreak, most of the community did not comply for promotion and prevention. They did not believe the severity resulting from coronavirus infections. There was a cognitive bias in the community, but currently only around 17% people do not believe in COVID-19. Second, pandemic has reduced visit to private primary care services by 30%. Hospital visit decreased by 50 to 60%. The district that have decided on the health insurance budget to refocus for COVID-19, the growth rate of contribution and benefit cost change, there is a decrease in the cost of benefit use and decrease in income distributions. Here the figure you show here, in this figure, show the effect of COVID-19 to the Indonesian USCJKN, which is run by BPJS. But I'm sorry, this is in Indonesia Bahasa. I take this figure from the National Social Security Council, DJSN. The yellow color is the amount of benefit expenditure. The white color is the income contribution. The right figure show the growth rate of contribution and the per capita benefit cost, which is during pandemic, the income contribution decrease and the benefit cost decrease. To answer the second question is related to the USC benefit package, which is according to the regulation, the JKN benefits do not include disease caused by epidemic. However, this pandemic has given BPJS additional management duties from the government. BPJS verifies claims submitted by hospitals serving COVID patients, which will be paid by the government through the Ministry of Health. This is the mechanism for patients COVID. Claims can be submitted by the hospital every 14 days, about 14 working days. BPJS issues a claim payment verification report claim for service bills not later than 7 days working days, whether it's clear or not. The Ministry of Health will pay the hospital within 3 working days, and a copy of a letter sent to the Health Regional Office for their monitoring. This is the BPJS will do the accountable verifications, verify the claim, and send to the Ministry of Health that the claim is clean. The challenge. The pandemic situation related to the implementation of universal health coverage in Indonesia face challenges that are interrelated with one another. First, public awareness. About 70% people do not understand COVID-19, which will increase number of cases and morbidity and or mortality rate. The second challenge is the claim payment process. Problem experienced by hospital in administrative and in COVID-19 service standard. There are around 1,711 of a total 2,917 hospitals that provide services for COVID-19. Of that number, only about 67% of hospitals have submitted claim. And the third challenge is how to restore economic recovery while coping with the pandemic. So what is the next step? We should involve community empowerment for the preventive and promotion to prevent the COVID-19, and we should work with the local government support and strengthening coordination among stakeholders and facilitation of various innovations. Thank you. I refer my speech to my colleague, Ibu Dr. Nani Isnyani from the District Tangerang Hospital. Please, Bu Nani.